Hello and welcome back to my YouTube channel. In this video, we'll delve into the pathology of renal system. So let's jump into the lecture. So the pathology of renal system is divided into the four main headings. Okay, so we study renal pathology under four main headings. What all these headings are: first is the glomerular injury, second one is the tubulointerstitial injuries, third one is the vascular injury, and fourth one is the neoplasm or cancer associated with the renal system. Okay, so let's start our discussion with the glomerular injuries first. But before diving deep into the glomerular injuries, we must understand the basic structure of glomeruli, so without which you can never understand the pathology of glomerular injuries. So diving into the basic structure of glomeruli, what it is made up of: it is made up of the Bowman's capsule. This is the Bowman's capsule, the black structure, you can clearly visualize it. It is of two layers. Okay, so it is made up of two layers. Outer layer is the parietal epithelial and the inner one is the outer layer is the parietal epithelial layer and inner one is the visceral epithelial layers. Okay, between these two layers there is space known as Bowman's space or urinary space. Okay, so what this space is called, it is known as urinary space. Okay, you have got this afferent arteriole which is bringing blood into the tuft of capillaries known as glomerular capillary, and from these glomerular capillaries blood enters into the efferent arterioles, okay, leaving these capillaries. Now suppose, let's assume that this is the light microscopic visuals of glomeruli, but with the light microscopic visuals you cannot fully understand what is present within these glomerular capillaries. Okay, so with the light microscope you can only see it as a single layered structure. Okay, but once you go through the electron microscopic visuals of this particular structure, you will realize that it is not a single layered structure, but it is the three laminar structure or trilaminar structure. It is made up of three layers. What are these layers? With the inner side, you will find the endothelium of the glomerular capillary. Okay, then you will go up. Okay, so go up, you will find that this endothelial layer is supported by the basement membrane, which is also trilaminar in this case. Okay, so the part of the basement membrane which is nearer to the endothelium is known as lamina rara interna. Okay, the part which is far from the endothelial layer is known as lamina rara externa, and the part which is present in between these two parts is known as lamina densa. Because why is it called lamina densa? Because on the electron microscopic visuals it appears to be dense. Okay, so it appears to be dense, that's why we use the word lamina densa. Then you have got the third structure known as visceral epithelial cells, and these visceral epithelial cells are also known as podocytes. Okay, these podocytes contain certain processes known as foot processes of podocytes, and these foot processes of these podocytes are attached to the basement membrane. Okay, and between these food processes you can clearly visualize that there is an empty space. This empty space is known as filtration slit. Okay, and this filtration slit is bounded by the filtration diaphragm, which is made up of podosin and nephrin proteins. So this much must be clear to you, and the structure as a whole is known as filtration membrane. Okay, so this much must be clear to you. I haven't left any stone unturned so far. Now, with this we have understood the basic of glomerular structure. Now let's dive into the glomerular injury. The patient with the glomerular injury is presented with the proteinuria, the hematuria, and lastly but not least, the cast formation in the urine. Okay, so these are the three main presentation of patient with the glomerular injuries. Let's talk about them one by one. Firstly, we'll start with the hematuria. What is hematuria? Hematuria is the presence of RBCs in urine. So, is this the complete definition of hematuria? If you find any patient, if you find anybody with this problem, with the RBCs in their urine, will you declare them as a hematuric patient? Not at all. You can never declare them until or unless you will find, until or unless you find more than 3 RBCs per high power field. Okay, still you cannot declare that patient as hematuria patient until you find 3 RBCs for three consecutive times at 1 week apart. Okay, then you can declare patient as a hematuria patient, otherwise you cannot. So the hematuria could either be glomerular or extraglomerular. Okay, so this hematuria could either be caused by some glomerular cause, and it could also be caused by some extraglomerular cause. The glomerular cause is associated mainly with the nephritic syndrome. Okay, so the glomerular cause is majorly associated with the nephritic syndrome, whereas extraglomerular cause is associated with the renal stones. Okay, renal stones or idiopathic hypercalciuria. So these 2 points you must remember, you must keep in your mind. Now, whatever the cause it may be, the hematuria, how can you distinguish the glomerular hematuria with the extraglomerular hematuria? How can you differentiate these two types of hematuria? Suppose you take the sample of urine, you put the smear. What will you find with the hematuria caused by the glomerular cause? You will see that RBCs present in this smear will be damaged. Okay, so whatever the RBCs you will find, they will be damaged. Okay, or dysmorphic, the appropriate word we use for it. Okay, so suppose you take the sample of urine, what will you find? The shape of RBCs or the geometry of RBC will be damaged or dysmorphic. Then you will say that the hematuria is because of the glomerular cause, and this glomerular cause is caused by nephritic syndrome. Suppose another patient comes to you, you take his or her sample, you found that RBCs are normal to the RBCs which are present in the normal person. So these RBCs are isomorphic, and you will declare that this hematuria is because of the extra glomerular cause. It's nothing but because of the extra glomerular cause. So with this we are done with the hematuria. Now let's talk about the another presentation of patient with the glomerular injury, which is the proteinuria. What is proteinuria? Proteinuria is the presence of proteins in urine. Okay. Do proteins normally present in the urine? The question must arise in your mind. Yes, proteins are normally present in the urine. The 2/3 portion of these proteins are TAM horse fall protein. Okay, so they are known as TAM horse fall proteins, which are produced by the ascending limb of loop of Henle. Okay, so this was about the proteinuria. Now proteinuria is further divided into the two types. One is the selective proteinuria, another is the non-selective proteinuria. Before understanding these two types of proteinuria, we come back to the basic. What was that? We know that the function of glomeruli is to filtrate the blood, okay, or to filter the blood, or we could say specifically the ultrafiltration. Okay, so this ultrafiltration of the blood is mainly depend upon the two factors. One is the size of molecules, another is the charge of the molecule. Okay, those molecules which are lesser than 4 angstrom in size, they are easily filtered through this filtration membrane. They are easily filtered through this filtration membrane. Whereas those molecules which are greater than 8 angstrom size, they cannot be filtered. Glomeruli, this filtration membrane will say no to those molecules which are over 8 angstrom in size. Okay, so this was the first factor which was affecting the filtration, the ultrafiltration of molecules through this filtration membrane. Another factor was the charge of molecules. Okay, we know that this filtration membrane is negatively charged. Why? It's because of the two reasons. One is because of the endothelium. This endothelium is the negatively charged because of the presence of salicylates, and also because of the basement membrane. Attached to this basement membrane are the glycoproteins which are negative in nature. That's why they give the negative property to this basement membrane as well. So whatever molecules in the blood which are negative in nature, they cannot be filtered. Why? Because this negative will repel the negativity present in the blood. So we know that albumin, most importantly, it is talked more. Why? Because albumin is also negative in nature, so that can easily be repelled by the negativity of this filtration membrane. So in the patient with the normal kidneys, with everything normal, the albumin is not seen in the urine. It's because of this charge factor. Okay, so now let's come towards the main part of the discussion, which is the selective and the non-selective proteinuria. On what criteria we divide the proteinuria into the two types? On the basis of clearance ratio of IgG to albumin or transferrin. If this ratio is less than 0.1, then we will declare that patient is having the selective proteinuria. So the question must arises in your mind, what all types of proteins are found in the selective proteinuria? Whatever the proteins I have mentioned here, the IgG, the albumin, the transferrin, all three types of proteins are found in the patient with the selective proteinuria, but most common of them, most important of them is the albumin. That's why this guy is being discussed more in the renal pathology. Okay, whenever there is any glomerular pathology, it is the albumin which is appear in the urine first. Okay, why? It's because of the less molecular weight, because of its less molecular weight, and also because of its smaller size. Okay, so it has got the smallest size, whereas very less molecular weight, so it appears first in the urine. Okay, this must be clear to you. The selective proteinuria is because of the defect in the charge. Okay, so it is the only defect in the charge. There is, so size is perfect, there is no defect in the size, but there is the defect in the charge. Where this selective proteinuria is seen, it is mainly seen in the minimal change disease. Just remember it, just mug it up right now. We'll discuss it in our proceeding sessions. Right now you just bother to remember it. Okay, so the selective proteinuria is mainly because of the defect in the charge. Okay, now let's talk about the non-selective proteinuria. On what basis we could say that patient is having non-selective proteinuria? The same scenario here also, on the basis of clearance ratio of IgG per albumin or transferrin. If this ratio is greater than 0.2, then we will say that patient is having non-selective proteinuria. We'll declare that patient is having non-selective proteinuria, and it is because of the defect in charge and size both. Here it was defective in only charge, but in this case the defect in both charge and size of the molecule. So where this non-selective proteinuria is seen, it is seen in the post-streptococcal glomerulonephritis, membranous glomerulonephritis, etc., and etc. Whatever conditions I have mentioned here, whatever examples I have mentioned here, you just mug it up for a time being. We'll study everything about it in our proceeding sessions. Right now you just bother to remember that thing only. So on the basis of proteinuria, we divide glomerular injuries into the two types. One is the nephrotic syndrome, another is the nephritic syndrome. We'll discuss both syndrome in our proceeding session in much detail. So thank you for watching my video. It was all about today's lecture. We are done with it.